بسم الله الرحمن الرحيم الحمد لله رب العالمين وصلى الله وسلم وبارك على نبينا محمد وعلى آله وصحبه أجمعين. نرحب بكم في السيشن لطب الأسرة للرابطة العمانية لطب الأسرة، وهي سلسلة من الجلسات العلمية المتعلقة بما يخص تخصص طب الأسرة والطب العام. Welcome you all to the series of the primary healthcare sessions and family medicine sessions, which is organized by the Oman Family Medicine Society, touching various related topics to the primary healthcare. Today's topic will be also in collaboration with the Dakhlya Primary Healthcare Committee, and we are focusing today on the COVID-19 and the control of NCD. We have good enriched speakers and also very well and enriched panel chairperson on our today's session. Just general statements. On the Zoom, you have the chat area. So you have difficulty with the voice or anything else, you can put it on the chat. You have also Q&As. You can put your questions on the which you target to the speakers. Kindly put the name of the speaker and put your question there. Other issues. If you have the question will be answered by the end of the session, and this session will be recorded and it will be uploaded to the Oman Family Medicine Society YouTube channel, so you can go to it anytime. And our session will last about 1 hour, and it will be led by our senior teacher, Dr.AbulAziz Al-Mahrezi. He is the chairperson of the Oman Family Medicine Society. Dr.AbulAziz, the ground and the floor and the table is yours.
Shukran. Thank you very much, Dr. Zahir. First of all, I would like to give my sincere thanks to Dr. Zahir Al-Anqoudi for his great efforts in arranging this series of webinars. And it's also a great pleasure for me to be here with you and to chair this session. The first session will be by Dr. Shadha Al-Raisi, and Dr. Shadha Al-Raisi is Director of Non-Communicable Diseases in the Ministry of Health. She is currently supervising the work on Ncd surveillance, the integration of most of the common chronic diseases and mental illness in primary care, the provision of peritoneal dialysis services, as well as the provision of services for those living with disabilities. And Dr. Shadha is well qualified. She holds degrees in medicine, biomedical sciences from University College of Cork, and a master's degree in public health from London School of Hygiene and Tropical Medicine. Dr. Shadha Al-Raisi, you can start, please.
Thank you, Dr. AbulAziz, and thank you to the organizing committee for inviting me to speak today. I am trying to share screen, but it says host disabled participant.
Okay, now you can start, Doctora.
Okay. Okay, so as I said, thank you very much for the interest in this topic. I was asked to talk about the assessment of services for patients with chronic diseases and psychiatric illness during the COVID-19 pandemic. So as you may all know, during the pandemic, there was a reorientation of Ncd services and psychiatric services that had to happen for a number of reasons. We did have a growing number of COVID-19 cases, which resulted in the reassigning of healthcare providers to manage COVID-19, be it in contact tracing or managing or testing COVID-19 cases, but also some of our teams were being reassigned to hospitals as well. So there was always that limiting of patient-physician physical interaction, mainly to protect our patients as well, to avoid overcrowding and exposure to possible COVID-19 cases. So there was a reduction in number of patients that were seen in clinics. There was a withholding of services, mainly with regards to national screening or with the Ncds, the national screening program was being withheld. And different teams all around the governorates were developing different means to ensure the continuity of care. And this was provided through different platforms. So on the 16th of March, the Directorate General of Primary Healthcare had released its guidelines to try and achieve a standard method of what was being created in different governorates. So the protocol advised that NCD clinic lists were to be revised every week, and patients were to be categorized into those who were controlled and those who were uncontrolled. Patients who were controlled were provided with a new follow-up appointment, and they were prescribed 3 months of medications, and they were requested to collect medications every month. Later on, the Directorate General of Medical Supply allowed the supply of 2 months of medications every month. And the patients were encouraged to have a relative collect the medications. Patients who were uncontrolled were encouraged and advised to attend their appointments. As I said, the NCD screening program was also advised by the ministry to be withheld, and healthcare providers were being encouraged to provide phone consultations. So the many messages that were given across the social media platforms and the Ministry of Health was similar to this, advising those with chronic diseases to avoid visiting healthcare facilities unless absolutely necessary. But the other different interventions that we were seeing, and I'm only putting up a few, but there were so many excellent initiatives that were taken by different teams in the governorates. And I've taken a few, this is from Dibba Hospital in Musandam, where a team of family physicians there had advised or had given out phone numbers so that that continuity of care would be support, or patients will be supported through those means. But then there's another message here that I'm displaying from Qasabiya Health Center in North Baltana, where numbers were being shared for results to be given over the phone, for appointments and rescheduling of appointments, and so similar other services. So as I said, these are just different things that were happening in different governors, but there were also mental support lines that were being provided as well. Masarra Hospital was doing the same, and different teams around the governors were doing the same. Now, so as a result, what we had done, we were in an uncharted territory. This was a new thing. We were always used to the provision of services, but all of a sudden we had to stop that provision of services. So it became very necessary for us to see exactly what was happening. So we conducted an assessment on the impact on reorienting Ncd services on patients living with Ncds, and this was done from March to May 2020. And this was soon followed by another assessment in June to August 2020 to assess the impact on psychiatric services, on patients following up on psychiatric services. So the main objectives of these assessments were to assess the accessibility and availability of medications during the pandemic, but also to assess the extent of coverage of the newly implemented initiatives. We also wanted by these assessments to reach out to patients who may report not having received medications or who may have any issues so that they can contact or our teams can reach out to them. We also wanted to assess the feasibility of conducting a rapid assessment, and this was absolutely important because in the Ncd surveillance section, we're used to having the team going into the field to look through different registers and different documentations in the Shifa system, in the electronic system. But as a result of the pandemic, we were unable to do that. So we had to assess the feasibility of conducting such an assessment at a time of crisis. And finally, to provide a basis for future work in developing guidance for essential health services. Now, the participants were mainly patients that were following up in primary healthcare chronic disease clinics, mainly diabetes, hypertension, and asthma clinics. But also for the assessment of mental health services, the participants were patients following up in psychiatric clinics. A structured self-administered electronic questionnaire was developed in Arabic, and this was developed and reviewed by the Department of NCD and WHO EMRO. A link was also developed and communicated by the team in the facility to a sample of registered patients with NCDs and PHC and those following up in psychiatric clinics as well. Now, as I said, it was a new method, so we needed to ensure the engagement of all the teams and the governorates. So there was an official communication that was sent to all directors of primary healthcare and all governorates, sharing all details of the assessment that included a proposal with the methodology and the time frame, and also the NCD heads of sections and mental health focal points played a big role in these two assessments. They were briefed on the assessment and methods and were sent a link to the questionnaire to forward to patients, and they were provided with progress reports to ensure the close follow-up during the course of the assessments. They were also provided with a list of phone numbers and comments that were left by patients, and in response to concerns and issues raised, the teams were contacting these patients. Now, during data collection, there were daily assessments of the responses that were made, and progress reports were produced to ensure the adequate number of completed questionnaires. Now, with regards to the assessment of Ncd services, we had a response rate of about 59%, with a total of completed questionnaires about 2,387 questionnaires. Now, we had less so with the mental health assessment. We had only about 502 completed questionnaires, but again, the response rate was about 56%. Now, in terms of the assessment of Ncd services or the even the mental health assessment, there was considerable variation between the governorates. And it really depended on the capacity of different governorates to actually conduct this assessment, but also different coordination issues that were seen to have resulted in different governorates as well that hindered their capacity to actually develop. But also with the psychiatric services assessment, it tended to be very low and slow during the process of this assessment. And this could be because the NCD clinics do have NCD registers where the patients' numbers are readily available, but not so for the psychiatric services. So in terms of the assessment of Ncd services, we had 60% women and 40% men, and the majority being over from 40 and above, resembling a similar situation that we are seeing in our chronic disease clinics. In terms of the assessment of psychiatric services, the gender distribution was 50-50. And the age group, the majority were from 20 and to the 59 age group. So in terms of the assessment of Ncd services, we discovered that there were less than 40% of our respondents had reported being contacted by their facility during the pandemic. 98% of our patients have reported receiving their medications, so either by collecting their medications from their facility or having the medications delivered to their homes. Luckily, only 6% reported incomplete prescription, and we did ask questions on whether patients were self-managing their diseases at home, and we found out that a higher proportion of diabetics, about 75%, reported measuring their blood sugar levels, and this was compared to only 43% of those with hypertension. In terms of the assessment of psychiatric services, more than 40% reported deterioration in their condition since the start of the pandemic. 50% of respondents were able to reach hotline services. 30% reported being contacted by their health facility, and more than 80% reported having their last follow-up in the previous 3 months. And more than 80% reported collecting their medications from their facility. Also, 14% of patients reported side effects, and 60% were able to be evaluated in mental health clinics. And finally, 87% of the respondents reported being satisfied with the services provided to them. Now, I know this slide is a bit fuzzy, but I just wanted to share some of the comments that were sent by the respondents. Yes, we did get a few negative comments, which were always shared with the teams. All comments were shared with the different teams in the governance so that they could respond to the patients. But luckily, we had so many positive comments mentioning names, mentioning health facilities. And that was something that we were very happy of and very proud of. Now, these assessments had led to continuous work with the Department of IT on trying to make sure that the telemedicine clinic as a module was available in a Shifa system, and thankfully now it has been disseminated to all governorates. Also, we are continuously working to develop the SOP on the use of telehealth and telemedicine for running Ncd services in primary healthcare. And some of our messages were also tailored to towards telemedicine in order to ensure that these consultations are running smoothly. So we were encouraging patients to follow steps prior to the consultation. Also, it helped in introducing strategies and interventions that help patients and their caregivers to self-manage their diseases. Now, the department had worked in the past with private pharmacies to help ensure that patients were able to get different home devices at discount rates. I'm very thankful for the NCD control section in the department who were contacting every pharmacy, making sure that we had enough stocks in the pharmacies in all governorates so that these discount cards could be supplied again and patients would be able to receive or collect them from the pharmacies. It also helped in developing this SOP for the provision of psychiatric services with the roles and responsibilities of all those involved. Now, challenges and limitations, as I said, there were considerable variation in the number of responses between governorates. Some governorates had challenges to recruit more patients as their contact numbers in the medical record system were not updated. There were lack of registers for patients following in psychiatric clinics. Some psychiatric hospitals or services are under hospitals and not primary healthcare, which created an issue with the coordination and having to contact the administration of different hospitals, but also at times there were coordination issues between different teams. And we could sense this more with the mental health assessment, which really made us want to develop the SOP to help resolve this issue. So the recommendations as a result of this assessment, there is a need to enhance and scale up the patient's registration system throughout all PHC facilities and ensure that all governorates are at the same level of capacity of engagement and participation. But there is a need to support this method of rapid assessment, for example, by developing local methods of developing electronic questionnaires, analyzing data, and developing national databases. As I said, with the NCD surveillance, not every method of assessment can be carried out using a study. This was absolutely necessary to really get the information very quickly. And as I said, we were unable to actually go into the field, but we really need a database that would allow us to reach out to patients or even reach out to data of patients so that we can make decisions very quickly. So the system of delivering medication seemed to have worked and may be worth expanding and ensuring is in place during a crisis. And this is my final slide, but I had to thank and acknowledge everyone who was involved in these assessments, those from the Department of NCD, the NCD Surveillance Section, NCD Control Section, and the Mental Health Section, but I also have to thank the departments of primary healthcare in all governorates for their extensive work in this assessment, as well as those in the psychiatric services, but also the surveillance unit in WHO EMRO in Cairo. So thank you very much again, and over to you, Dr. AbulAziz.
Thank you very much, Dr. Shadha, for this informative and illustrative presentation. And I'm sure that it will stir a lot of thoughts and a lot of questions from our participants. The way to ask questions, as Dr. Zahir mentioned to you, the chat box is from the chat box in the Q&A areas. And also we'll open the floor for questions once we complete the presentations. So we'll dedicate special time for all of your questions at the end. Our next speaker is Dr. Badriya Al-Farsi, and Dr. Badriya Al-Farsi is a consultant family physician, acting hyperbaric medicine consultant at Saeed bin Sultan Naval Base. She is the chairperson of family medicine residency program at OMSP, and she holds the MRCGP International and a fellowship in family medicine diabetes care from the Imperial College of London. Dr. Badriya, the floor is yours.
Thank you very much, Dr. AbulAziz and Dr. Zahir, for your invitations. And thank you, Dr. Shadha, for your nice work you have been doing. And thank you for giving me this opportunity to share with you what we are doing in Armed Forces Medical Services. I hope I can share, yes. This is just a short presentation about our service in Armed Forces Medical Service. And my outline of the presentation will be the introduction about Armed Forces Medical Service, how is it structured, and then we'll go for why patients are, as Dr. Shadha mentioned, that the flow of patients was decreased. They are not visiting the health facilities, and how we managed in the primary care, and we'll speak about few challenges. To whom Armed Forces Medical Service consists of hospitals, which are Armed Forces Medical Hospital in Muscat and Armed Forces Medical Hospital in Salalah. And there are 3 large polyclinics, which is a military polyclinic in Muscat, and Said bin Sultan Naval Base Polyclinic, and Shafa in Iski Medical Center. And there are other health medical centers or health facilities, which is located in different camps. If we look at the primary care, mainly we have the military polyclinic in Muscat and Said bin Sultan Naval Base Polyclinic in Al-Batna region, Shafa, which will be in Dakhlya, and there are other units which is located in different, all over the country. As it was mentioned that there was a decrease of patient flow to visiting the healthcare facilities, which is mainly because patients are fearing from catching the disease or contracting the COVID-19. And another reason maybe could be that they are obeying the instruction where there is lockdown, and there is a lot of, as Dr. Shadha mentions, a lot of asking the people to stay back at home if they are not suffering of anything, only just for their medication they can consult. And there is some, for us as a military, there was priority for forces health, that we want to keep our troops and our forces as healthy as possible. But we want also the healthcare providers in the health center or healthcare facilities to be healthy and to be able to serve these people, so are acting as a frontline, as in frontline. Also, there was a mobilization of services, as we mentioned. There is some people who have been, some of the healthcare providers being moved from from the primary care to the hospital to cover some, especially then from the nursing sites to cover the COVID service. And there was a general situation which is due to the lockdown that's led to a decreased number of patient flow to the health institutes, because as a military, as a healthcare provider for all the militaries and their dependents, it is all over the countries, and it is not localized to certain governorate. This is kind of during the lockdown, we need to keep these people as healthy as possible. But there was a collaboration between, in my opinion, collaboration between primary care and secondary care, which is hospital, giving us a good and excellent care for our patient. And just speak about one example of this collaboration between Armed Forces Medical Service and other big units, which is the Said bin Sultan Naval Base and in Shafa, that was located in Dakhlya. Armed Forces Medical Hospital, Armed Forces Hospital in Muscat, they developed WhatsApps for refill of medications, and for providing the service of this medication to the patient as to the nearest points to their locations or where they are residing. We have Said bin Sultan Naval Base, which is in Al-Batna region, and it can cover from peoples from Al-Zahra. They can collect to at the Said bin Sultan Naval Base because it is near to them. And peoples from Dakhlya, they can collect their medication from Shafa. But there was a continuous collaboration between Armed Forces Hospital in Muscat and the other units in Armed Forces services. And Salalah, thank you for sharing with my colleagues from Salalah. They are they used to get through to, they look after the patient through two options, either by unscheduled visit to emergency department, which is even they use it for non-emergency services, or through SMS. They were like looking for the patient who are due, for example, for medication, and they send them SMS, and they give them time to allocate it to collect their medication from the pharmacy. But according to the colleagues there, that it was very challenging because there is no updated numbers in the patient records, and it was very difficult, and they have to stop the service. And they started to see patients with limited numbers. What we did inside Bin Sultan naval-based polyclinic to manage such situations, initially there was like a general measure, which is the cancellation of appointment. We are like, mainly our patients are diabetic, hypertensive, and thyroid diseases, which is a bit, I mean, it's compromised a lot of our non-communicable disease patients. We canceled these appointments. Also, the ophthalmology referrals to the hospitals was canceled. Others, because as you know that the hospitals also, they stopped their services for certain periods. We established hotline for COVID-19 for any inquiries, and patients are encouraged to use the hotline for any queries. We established also the WhatsApp services for refill of medication, which was initially, we started the WhatsApp to be held by the receptionist to register the patient, and then to take the physician to prescribe the medication, and then to the pharmacy. But we faced also problems then, because receptionists cannot respond to the patient's inquiry through WhatsApp. It was held by our pharmacists who did a great job in this service, and they were proof that they can handle such a service. Also, through the health messages, which is daily, we are having through SMS to our RNO staffs, Royal Navy of Oman staff, through their mobile number. So we just send brief health messages to our central controls to send to disseminate to our all other staffs in the Royal Navy. And these health messages also contain landlines numbers and the hotline numbers for any inquiries. Also, we established a triage as other hospitals or other healthcare facilities, the entrance, and we are ensuring that the social distancings were kept maintained in the waiting area. Another things, because of we have the people who are most of our patients are dependent of the staff in the base. What we allowed these people, the caregiver, to come and discuss the home monitoring of their family, like parents or the people who are there with the doctors and the physician. And this is encouraged through also the SMS services. Physicians are also instructed to look at the health records of the patient while they're prescribing medication to give more advice, like if the patient needed to be seen earlier, or stratification of the patients. For the patient, we gave the instruction for home blood pressure monitoring or diabetes monitoring. And as I mentioned before, and this is an example of like blood pressure monitoring, home monitoring, and this can be discussed either through phone consultation or through caregivers coming to the healthcare facility. Also, because of the lab appointments were also withheld, we started to reschedule the investigation for a patient who are like missing their follow-ups, or they need to have an earlier investigation to be done. And we instructed them that they should come directly to the bleeding room, and we make the visit as short as possible. and with limitation of the patient, of the persons accompanying the patients. And also, they were encouraged to discuss their inquiries about their results through landlines, which will be provided during their visits. As I mentioned before, the using of WhatsApp line services for refill of medication was maintained till now. And this is, as you can see, the numbers of prescription through WhatsApp services. And you can see this is when we started in March, and it was increasing after the people had know the service and they are able to use it. This is a kind of the package of the medication. And another thing to facilitate our help to the community, that because some people were not able to enter the camp, we used with collaboration with the gates to keep a fridge there and keep medication for 48 hours. And the people can collect it from the gate, the entrance of the base. And we put the dates, and here will be the patient's names and the ID of the patients. After opening, as you know, that we started to see more patients and walking patients without appointments. And with this, we started to reschedule their appointments and according to their needs, like the time will be allocated according to the patient's requirement or control of the disease. Another service which is also it came in the right time is the fundal camera, because we stopped referring patients for diabetic retinopathy follow-up screening and follow-ups. But the process of fundal camera is the installment and of the fundal camera and these services are in process, and we already got our optometrist who is trained in this. This service will help us in collaboration with armed forces hospitals, because they will be on as a digital collaboration. We can send the images to FH, and the ophthalmologist will look at it, and if there is any need for the patient, they can prioritize the appointments accordingly. With the start of the vaccination, we are not yet providing any vaccine in our polyclinic. Any patients who are coming asking, like we advise our patient to go to Ministry of Health to get their vaccination, and we can provide them with like a certificate or that stating their health conditions, if they are diabetic, hypertension, or any chronic diseases. What challenges is the needs of risk stratification, as I mentioned, for a patient, and also I think a big challenge is the training of staff on telemedicine, how they respond, how they document, how the times allocation for this also will be needed. And this will need also training of the staff. And we started to see increasing in number of uncontrolled patients. Other, which is I felt also a need to work on it, is the digital literacy of our patients, because most of our patients are not able to use the new like the apps or using emails or WhatsApps. Another challenge is the uncontrolled patient and their visit with the limitation of number of patients is required, and how frequent we need to see these patients. Also, we need to work on this and to maintain the visit as much as needed. There was a financial difficulties in patients, because we were encouraging the home monitoring of the disease, but unfortunately some patients, they cannot afford to buy like BP monitorings or for blood sugar, the strips, which is they were facing also difficulties. we got some collaboration with some of the pharmacies to get some of these strips for diabetic patients. That's what I hope I gave you some of what we are doing, and thank you very much for your giving me this opportunity. Thank you very much, Dr. Aziz and Dr. Zahir.
Thank you very much, Dr. Badriya. Thank you for sharing your experience and the lessons that you learned, which I'm sure that they're very useful to everyone and to all the places in Oman. Thank you very much. Our next speaker is Dr. Laila Al-Saadi, and Dr. Laila comes from all the way to us from Al-Buraymi. She's the head of the non-communicable diseases in Al-Buraymi government. Dr. Laila.
دكتورة ليلى إذا تشغلي الميكروفون سمحتي.
Assalamu alaikum. And you can hear me now?
Yeah, very clear.
Yes, Dr. Yes.
Yeah. Thank you, Dr. Zahir, for you give me this chance to be with you. And thank you, Dr. AbulAziz. Thank you for all the participants for attending this nice workshop. When Dr. Zahir, he asked me to give an overview about some of the initiative we did in our Buraymi Governorate during the COVID-19. I think that the most important initiative which can be done during this pandemic is the Telemedicine Trial. And I will talk about our trial in the Buraymi Governorate, which helped us a lot. I will talk about this agenda, why it was started, and what is the structure needed for implementation, how it was implemented, and I will talk about some of the obstacles and our future plan. Why it was started? It is obviously to continue the follow-up of our patients, especially the uncontrolled cases, especially it was started during the lockdown, but we continued after that. A structure needed, of course, that we need an office, and I prefer to be a separate office for the privacy for the treating doctor and also or the treating nurses. It should be a Wi-Fi, or better to be a Wi-Fi and a landline to contact your patient. Smartphone, of course, with a SIM card, and a Shifa 3 Plus, very needed for documentation of our notes. Implementation, before I will start the implementation and the process of implementation, Dr. Zahir, if you can put the polls for the audience to hear from the audience, and I'm sure that most of governorate, they did like this telemedicine and they implemented. So if we can hear from our audience, question 1, what is the most difficult steps in implementing the telemedicine? Is it the preparation of the structure, or the patient acceptance, or updating of the mobile number? The 4 is the unavailability of the glucometer and other machine needed to follow our patient.
You can put your answers on the poll area on the screen.
This is to hear from your experience, actually. If we can give them 1 minute or 2 minutes. 1 minute. 1 minute is enough.
ويمكن
We cannot vote. You're not allowing the.
أنا أعطيكم الفوت إن شاء الله المرة الجاية إن شاء الله ثاني. ويمكن يكونوا بايس شوية ولا شيء. Okay, think the second session we will get the option. I think we got almost like 60% who voted.
Yeah.
أظن نكتفي دكتورة.
Okay, so I don't know if I can know the voted.
Okay, this is the okay. Now I'll share the screen with you. Okay, share the screen.
If it is not possible, or for preparing of the structure and patient acceptance, and 44% is as I expected, and as it is in our this one governorate. Okay, let's go in our presentation and see how we implement our this one. Okay, actually, we implemented this, I think there was, okay. We implemented firstly in Al-Buraymi Wilayat as it is covering more than 80% of our NCD cases. And then we expanded to all of our health centers in Al-Buraymi Governorate. We have actually 7 health center and 1 polyclinic. And polyclinic is covering all of our NCD cases. Actually, we started for the diabetic cases and GDM cases with hypertension. And then when we found that it is useful for our patient, we expanded to asthma clinic and screening above 40 clinic. And now for other department also, they are using the telemedicine like MCH and other programs in primary health care. Who can run the clinic? In my opinion, actually, it should be run by the doctor. And it depends how you are running the telemedicine and for what you are running the telemedicine. Is it for only health education or for prescribing prescribing of medication as we started? But if it is to give the patient result of the lab and adjusting medication and reading the SMPG, reading the BB and monitoring their medication, it should be run by the doctor. Sometimes it is run by health educator, diabetic health educator, and why I'm emphasizing only on diabetic because it is covering most of the NCD cases. But for example, for asthma, it was run by the asthma doctor, GB doctor who is trained on asthma focal point doctor, and also or it can be covered by the asthma focal point nurse. Well, NCD above 40, of course, by the NCD focal point nurse. Our process, it was in the start as filtering the appointment patient, and this is especially during the lockdown, and assess the control of the cases. If the patient is controlled, so we are asked them to collect the medication, and unfortunately, this makes the patient dependent. And the uncontrolled, we call them and we ask them to come in their allocated time. But now we are doing the filtering in the reception of the clinic, and we are using the telemedicine for giving the patient lab result and adjusting his medication accordingly, reading the SMPG and reading the blood pressure and consultation. And what we noticed that in the beginning, the patient was dependent on us and they are asking only for medication. But now, alhamdulillah, most of our patients, they are having their own self-management at home, and they are consulting us for their annual assessment and also for adjusting medication according to the SMPG, BB reading and peak flow meter. And this is, I will show for you a 1-minute video for showing how to do the filtering of the appointment, as it was difficult for us in the beginning, but now it is much easier. Actually, you can find it in Shifa system. You can go to the appointment multi-query and you will choose the group as normal appointment, choose the clinic according to your appointment clinic, and then put the time or the date for the appointment you want to do filtering for them. For example, I want to do filtering for the appointment, tomorrow appointment. Then you will press for the print list, and it will come with patient number and mobile number and patient name, patient ID, and only you need to filter if it is control or not control and go ahead. For documentation, which is very important for the continuation of the care and also for your doctors and your colleagues to know whatever has been done in the telemedicine, we are documenting it in the addendum and in the addendum of the patient as the video showed. And this notes, actually, you will choose the consultant, and you will add your notes, whatever you did for your patient, and this will appear in the summary of the last visit as it will be shown now. So your doctor, when the patient will come for the next appointment, it will be easier for him to know that whatever you did for this patient through the telemedicine, okay? This telemedicine initiative, actually, it lead us for so many initiatives. If we can see, it is a mini initiative. Actually, we said that we are filtering our patient, and so this helped us in rearrangement of our appointment system, as I will show it in the next slide. Community online competition, and actually we expand this community online competition. We are showing video for the patient. It is an educator video, and then we will ask them some questions, and this is all online, and we will give them a gift of glucometer or BP monitoring, BP machine, or peak flow meter, or nebulizer, according to the patient. Actually, we are doing separate competition for each program. And actually now we expanded, alhamdulillah, WHO will fund us for a big competition. We will do it inshallah in month of March, bismillah, and it will help us in increasing the numbers of patients who is on self-assessment, and of course for counseling them. Annual assessment clinic, and still we are in the trial, and actually we started by November, and we found that actually during especially 2020, so many patients of NCD patients, no lab done for them. So what we are doing, actually, we have electronic system register for all NCD programs, and we are taking how many patients who visit our OPD and how many of them has been registered, how many of them has been defaulter, and how many of them annual assessment not done for them, and we are calling them and we are allocating them in separate clinic, because it takes, as you know, by implementing the diabetic module especially, it takes more than 20 to 30 minutes for doing the annual assessment for these patients. And of course, during the pandemic, we didn't stop our training, and this led us to do a diabetic module training module. And alhamdulillah, recently the NCD department, thanking for them, they reviewed this, and also Dr. Yusuf from Batna region, he helped us. Also Dr. Ahmed Al-Kalbani, he worked with us in reviewing this diabetic module training module, which is for us easier to train our colleagues, our GB doctors. And GDM clinic, actually GDM clinic, it was run by the ANC department, and also in collaboration with diabetic clinic, and there was late of assessment, late of management and diagnosis, but now we are running it once per week in ANC clinic, and it is run by diabetology. This is the arrangement which I was talking about it. We was putting our clinic as diabetic clinic 1 and diabetic clinic 2, but now we put it annual assessment clinic, control clinic, and uncontrolled clinic. In case la qaddar Allah sar lockdown, it will be easier for us. This is one thing. The other thing also, we are giving allocated time for each patient according to the clinic. Annual assessment clinic, we are giving 30 minutes per patient, and control clinic 15, and uncontrolled clinic 30 to 45 minutes according to the case. This helped us in arranging, as I said, this is already I mentioned it, and also, yeah, distributing the patient equally for our doctors, because our colleagues was saying that most of our cases is uncontrolled. It is difficult for me. So in the reception, they are distributing the patient according to the control of the cases, and also helped us in implementing the diabetic module, as I said before. Of course, in any initiative or any new things, there is an obstacle and there is an advantage, and the advantage, of course, it is more than the obstacles. It is strengthening the relationship between the treating physician and the patient. It helps in continuation of the counseling and educating the patient, monitoring the blood sugar and blood pressure and the ACT score of the patient, helped in teaching the patient the importance of self-management. And obstacles, of course, the availability of no proper place, and that was in the beginning, but alhamdulillah, it was solved. Unupdated numbers, still we are facing problem in updating number, but we are working on it. I don't know if Dr. Zahir, we have time. I want to put the polls, the second question.
Yeah, there is a time, I think. We can launch it.
Yeah.
And answer Dr. AbulAziz and other colleague.
Thank you.
Because I want to hear from the audience what is their opinions regarding what is the best way in updating the patient mobile number, because still we are facing some difficulties. So we want to know from your experience or your opinion. نعطيهم 1 minute.
Yeah, that's okay. All of the above issue people goes for usually. All of the above answer usually people go for, but I think you can get for like this
answer 1 and 2 and 3.
Yeah, but I think the question goes for the best way.
Yeah, the best way.
Dr. Ibrahim Taha, إذا تحطه في البولس answer, you can answer your question. I think we got 60% voted.
Okay.
Now 62 coming up.
Answers?
I think shall we stop? Already we got like 62, 63%. What about the doctor?
لا خلاص. We can go. One of the obstacles also the unavailability of the glucometer and blood pressure machine. And as I said, that was through the competition. We okay, 53 announcement. Yeah, this is, I didn't try it. I try the first one and the second one. Still we have big numbers, still not updated. So today, while I'm writing the question, I think for the 3, which is the announcement for the patient, and tomorrow, inshallah, I will do it for my clinics, inshallah. I hope it will help us. Okay, so let's continue. Unavailability of the glucometer and blood pressure machine, as I said, that through the competition, we distribute so many, alhamdulillah, glucometers and BB machine, and this helped us with our patient, because self-management, especially during the COVID-19, it was helping us a lot. So I think this is all for me, despite all of the obstacles we faced in telemedicine and implementing of telemedicine, but it solved so many difficulties during this period, and we are planning to expand it and to continue it in much better way. Thank you very much. And my big thanks to all of you who is attending, Dr. Zahir and Dr. AbulAziz, and for all of my colleagues also. Thank you very much.
Thank you very much, Dr. Laila, for sharing your experience in Al-Bremi, and it's really a great and like experience for us all to think about when we think about new ways to cope with the pandemic. Meanwhile, I would like to announce that unfortunately, due to some emergency, our fourth speaker, Dr. Hassan Al-Balushi, could not attend, and so we are sorry about that, and we hope next time if we have a future event that you'll be able to join us, inshallah. Now I think we'll open the floor for any questions. So if anybody I think has a question, they can unmute their mic and they can say their question, and if the question is addressed to one of our speakers, please mention her name so that we know the question is addressed to whom.
So to ask the question, there's an option on your screen to raise your hand. So if you can, so we can allow you to speak the question. The other option, you can put it on the question and answer. So we had somebody raised hand and stop it. So meanwhile, the doctor can ask Dr. Badriya Al-Farsi regarding, you have mentioned about the control of NCD disease. I mean, what do you think the factors which had made to the increase of uncontrol of some of the, clients of NCD?
Actually, because stopping the appointment, in my opinion, because patient-doctor relationship, it helps sometimes for educating our patient to keep lifestyle, to stick on their lifestyle changes. Another thing, patient continue using, if they need to adjust medication during this period, it is not adjusted. This is something which is, I think, also one of the reason which is increased the number of uncontrolled patients after this period of time. Another issue is that unavailability of self-management at home, like self-monitoring of blood sugars, which is patients are not able to do it. As I mentioned, because there is a patient who are not able to, able to buy the glucometers, or they are unable to check their blood sugar at home, and there is no caregiver who is able to do for them. And most of our patients are I don't know if others shares with me that they are dependent on the physicians on the cares. They are not used to self-management of their disease. But I think we need to increase our patient education regarding the self-monitoring of their illness, and as a shared plan between doctors and patient themselves. Thank you. I hope I answered.
That's just clear. Can I ask a question also, Dr. Aziz?
There is a question on the.
Okay.
We have one question,
okay,
and so it's to the questions addressed to Dr. Laila. How do you arrange the patients for annual blood investigations for those who need it most? Do you allocate them time and date, or just ask them to come fasting on the next day, or whatever day is convenient to them?
Yeah, actually, first of all, Dr. AbulAziz, and for those who is asking, annual assessment, as I said, that we have electronic register. So what we did, we actually this electronic register, it after completing 1 year of the lab of last glycated hemoglobin, especially if it completed 1 year not done for the patient, it will give us alarm. So from that alarm, we took all of these cases who has been giving us alarm that this patient is not done for them lab. And it was big number, especially during the lockdown, there was no lab. Then we will call them. Arrangement in the clinic, actually we put a separate clinic, and I decrease the numbers of patients who has been seen by each doctor. For example, I give each doctor each day in the control clinic 20. So I decrease that 20 to 15, and I give that number for the annual assessment, and I put it in separate clinic. So I'm receiving, our doctors is receiving 3 per clinic per day, each for whole days of the week. So it is run 5 days per week, and it is around 6 to 10 patients per day to be done for them annual assessment. From the annual assessment, actually we can catch our patient, and this which make our patient is not dependent on us. In the beginning of implementing the telemedicine, they were only asking for medication, only asking for proxy. But now if we did lab for them, and from the lab we counsel them, it is much easier for us to adjust for them, and they are listening to us. I hope that it is clear and answered.
Dr. Laila, on the same, around the same issue, I think there was a question about where do you get, did you get your glucometers from? Is it from MOH or some other place?
لا والله, in the beginning it is by owners, متبرعين from different persons. Now, alhamdulillah, as I said, the WHO will fund us for more than 50 glucometer. and more than 50 blood pressure machine. We wrote our proposal for our competition, and they agreed to support us. But in the beginning, it was only by متبرعين, يعني من الأونرز من الجوفرنوريت itself.
Thank you, Laila. So another, you are very popular, huh, Dr. Laila. Most of the questions I think are they addressed to you today. So there's a question from Dr. Zuwaina also. She's asking about the clinic, whether you are allocating a doctor for full duty, like 7 hours, or how do you conduct this clinic?
For telemedicine?
I think she means telemedicine. She mentioned virtual clinic, but I think it's telemedicine.
Yeah. Doctor who's asking for this, it depends. It depends on how many patients you will receive through phone. Yani in the beginning, we was putting only 1 to 2 hours run by the doctor to answer the patient. But now we have more than 25 patients, and most of these patients is uncontrolled, and we need to adjust for them. Okay. So now we are allocating one doctor for the telemedicine in Al-Buraymi Wilayat, but for whole 7 hours. But yani, this doctor actually, it is run by me. I'm taking the administrative work, and at the same time I'm answering my patient. But in the health center, it is not for whole 7 hours. The doctor who is running the clinic, he will take 1 to 2 hours to answer our patient in the beginning of the day, and in the mid of the day, and in the end of the day. So it depends on how many patients you are receiving through the telemedicine, yani through the phone.
Thank you, Dr. Laila. Also there is a suggestion from Elsa to distributing nebulizer machine also to patients who need it, since nebulization is limited in the polyclinic. Maybe they're, I don't know, like in terms of price, maybe they're more expensive. Do you have any idea, Dr. Laila?
No, it is yani, in our pharmacy, they give us by 15 riyals, and BB machine by 15 riyals. And actually we took some pharmacies, yani, they give us yani, discount price to take a BB machine with the nebulizer with a glucometer around 40 riyals, around 40 riyals. Okay, so we will buy this as 40 riyals, and we will distribute it according to the patient. But here we are taking it by 15.
Okay, another question from Dr. Muhammad Al-Ghafri. Is there any medical legal aspect that they should take care of in implementing telemedicine? Do we have any national policies regulating this project?
Doctor, I think Dr. Shadha.
Yeah,
yeah, because they are working on it.
Yeah. I had to turn off the video because I was losing connection. But with regards to the policies, we are working on developing the standard operating procedure. It is being validated by the Quality Assurance Center. There are still discussions back and forth with regards to some aspects of it, especially with regards to consent. So during the pandemic, we realized that telemedicine was getting obviously the main mean to contact patients. So it became very important for us to ensure that all teams were medical, as you said, Dr. Muhammad, that they were legally protected as well. So that was the purpose of developing the SOP. But as I said, it is still in the validation process, and hopefully I'm hoping that it will be out within the next few weeks.
I think around the same issue, Dr. Shadha, also another follow-up question is about like, is there any plan to rely on telemedicine after COVID pandemic? I think you already touched on it, but maybe more focused on this.
Would you like me to answer that, Dr. AbulAziz?
Yes, please.
With regards to telemedicine, from our visits during the pandemic, especially in the past few weeks, it seems that telemedicine is there to stay. So be it at a time of crisis or if it's a mean to reduce overcrowding, but it seems that it is going to be there to stay. And I would I would imagine with the use of technology, we really need to catch up with what is happening in the rest of the world and telling it may be primitive here in Oman, but it is something that is advanced in all over the world, well, in developed world at least. So it may be something worth doing. Dr. AbulAziz, I just want to touch on the topic of nebulizers as well, because I think there was a suggestion to give it to patients. Is it okay if I just...
Yeah, sure, go ahead.
With regards to nebulizers, I would suggest that, yes, I understand that nebulization as a procedure has been, we've cut back as a result of COVID-19, but it may not necessarily be a good thing to send out a lot of nebulizers. Remember that patients may rely on nebulizer because it's easy to use, but they can definitely be able to use their inhaler and whatever device they have. So you just need to, and if it's a child, then you can use a spacer. You just need to make sure that they are following the proper inhalation technique. So you may not necessarily need to distribute a large number of nebulizers. However, in the ministry, we do have about 1,000 nebulizer machines that we are expecting from a certain company. And we are hoping to distribute it. But again, we hope that we don't rely on it, but we really need to make sure the inhalation devices. That's all. Over to you, Dr. AbulAziz.
Thank you very much, Dr. Shadha, for the clarification. There is a question about lab results. Can we send them by email instead of patients following up in the clinic if the patient's condition is controlled? And probably, I think the question is open to any of our speakers who would like to answer this.
والله يعني for me, I feel that the annual assessment, even if the patient is controlled, the issue is not on the control rate only. The issue in other labs, يعني regarding microalbuminuria, estimated GFR, CBC, low hemoglobin, many other issues. So يعني I feel the best is to see the patient in the clinic. But if it is يعني difficult, telemedicine can help if it is run by the doctor. This is my opinion. I don't think that email يعني it will be easy for especially Omani people, elderly.
If I can share an experience,
yes.
Dr. AbulAziz. I mean, in the Shifa system, you have like MWatch email. So like your name at mwatch.gov.om. So you can access it through Al-Shifa. So you can, if the patient requests like a report or like a lab result as the questions have been raised, so you can add it as attachment and send it to any email. So there's a possibility in the Al-Shifa system to send an email to the clients if they request for like an emailed lab reports. Yeah.
Thank you, Dr. Zahir. Yeah, for the university hospital also there was a plan, like they have something called patient portal, where you can send, for example, medical reports and lab results, also like results of images like CT or MRIs. But there has been some like reluctance from doctors. They're worried about the impact of this. Like some of the doctors said, maybe if you send them a CBC, but there are a lot of things which are like out of range, then you'll be getting lots of calls and people will not understand the results properly. So it's still under discussion, but I don't like the facility is there, but it's not implemented because of this fear. Like what would be the impact on the patients themselves? Do they really understand these results, or is it going to like do more like harm and anxiety and fear, and so that's the issue. Anyone else would like to share their experience, Dr. Badriya or Dr. Shadha, about the email?
We are not using the emails now because it is not, implemented in our health information system. But I am with Dr. Laila that explaining to patient the results like through face-to-face or through telemedicine will be of greater use instead of sending it by emails. And as you mentioned, Dr. AbulAziz, sometimes the labs give us out of range and it is indicated with colors. and the patient cannot interrupt the result itself. It is not significant, like points of increase, or but they think anything's out of range is very significant. That also has an impact. Thank you, Tom.
You're welcome. Okay, so the next question, we move on to Dr. Laila again. How to solve proxy medications or proxy syndrome in brackets?
Yeah, proxy medication actually, it increased a lot during the COVID-19, and actually, still we are facing problem on these. What I did in our governorate, I found that most of our patients, more than 6 months, they are proxy. I don't know if other governorate, they are facing the same problem as us, because most of ours, we have lots of numbers of patients who are in UAE. Okay, so they cannot cross the border easily. So this is why we have no choice other than giving them the medication through the police and through the border. But regarding our patient who is living in Al Boraymi Governorate, I advise my colleagues there that if the patient is uncontrolled, to give the patient, if he sent his relative in the reception of the clinic, to tell the patient that we will give you for 1 to 2 weeks, and we reappointment for him and ask him that next time we will not give the medication. For the control, we can give them till 1 month. This is we started only by December, because only by the end of December, I took the database of our clinic from our register, and I noticed that there is many patients who was coming as proxy. So this is what we are now implementing. Maybe after getting another database, maybe we will change it. It is according to the situation. But now we are implementing like this. But for those patients who is in UAE, no other choice for us. We are giving them.
Thank you very much, Dr. Laila. Anyone else would like to add? Okay, so we move ahead again to Dr. Laila. Maybe the next 3 questions are again to you, Dr. Laila. Abdul Hamid Al-Siab is asking about Oman TV. Like, is it difficult to announce the need of updating contact numbers through Oman TV? If we do this, it will be a great job in strengthening the continuity of care during this difficult period.
Dr. Shadha, it will be a nice idea. It is really nice idea.
It is a very interesting.
Put it as this one as a poster or a message during this مهمتك معنا.
I think, but I have to say, I don't think it's just for NCDs though. I don't think it's just specific for NCD patients. I think it's in general, it's worth considering that patient information has to be updated in a SHIPA system. So it's something worth considering. So agree. I think we've come up with something very useful as well from this.
Yes.
Okay, another question, Dr. Laila, is the SHIFA 3+ electronic DM national register. Are you using this register or hard register?
We start. I think they are talking about diabetic module. Diabetic module we started by October. And I asked my colleagues not to stop the electronic register. No, we are using 2. Now we are working on 2. We are working on the diabetic module, which is run by the Ministry of Health. And we are using also the Excel sheet, which is we register as in a program. If your governorate want it, we can give it to your governorate. And I asked my colleagues not to stop this Excel sheet after starting the diabetic module. Why? Because I want to compare between the database from the actual Excel sheet and from the diabetic module. If it is in compare between each other, we will stop, of course, the Excel sheet and we will continue the diabetic module. But we trained our doctors and we are advising our doctors to use the diabetic module. But still, we cannot say that it can work well unless I want to be sure that our data is okay. So at that time, we can stop the Excel sheet and go on diabetic module. And actually, it is not only diabetes. It is diabetes, hypertension, above 40 screening program, and also this one, asthma program.
Thank you, Dr. Laila.
Welcome.
Anybody from our speakers would like to add anything in this? Okay, we move on. There is a question from Dr. Zahir Al-Mahrezi. What are the ethics and confidentiality measures taken in regards to telemedicine, especially in our society where some elderly are cared for by nieces, nephews, or grandkids and other relatives, which would not be appropriate to disclose some of the patient's information? How do you take this in consideration?
Question for whom?
I think it's for you, since that's telemedicine again.
Wallah, see, Doctor, يعني we know
maybe
that
maybe
يعني...
Dr. Shadha will help you also.
أيوة صح. والله يا دكتور يعني في النهاية telemedicine is not the best practice, but it was the best practice during the COVID-19, and we are not depending totally on the telemedicine. بالعكس يعني I found that يعني most of our elderly patients they are very, very happy that يعني they are feeling that their sons, their daughters, they are surrounding them, and they are taking them SMPG, the BB measurement, and they are contacting us. And actually we are talking, يعني sometimes I'm not speaking to the relative unless I'm speaking to the patient himself. يعني I'm sending voice message for them, or I'm calling them, and sometimes I'm calling them to attend the clinic. So it is not the best practice, but يعني it helped us.
Thank you very much, Dr. Laila.
I don't know if Dr. Shadha, she want to add anything.
May I just add just very quickly?
Sure, sure, go ahead.
Now, there are several considerations that we're taking. I think this is why the SOP is taking so long to come out, because we really need to cover different aspects of it. Also, different departments are involved in this SOP. So we have, for example, we have to work very closely with the Department of IT to make sure that, let's say, for example, the consent, is it a verbal consent? Is it going to be a signature consent? What does the telemedicine or the virtual clinics going to look like? Is it a photo, sorry, not photo, but is it an audio, or is it a video call? So there are different aspects, and that's kind of delaying the process. But we agree with all the confidentiality measures. We're putting different scenarios in our mind, things that was stated by, I think it was Dr. Sophia, that with regards to whether it was an elderly and then his son picks up the phone, or maybe someone else, a caregiver at home, who's picking up the phone. So we're taking that into consideration, and hopefully once we start getting all these inputs from different departments, we may have something that is complete, inshallah.
Thank you very much, Dr. Shadha. There's one question from Ahmed Zubair, and I think I had the same question in my mind. It's also addressed to you, Dr. Shadha. Any record of the impact of missing non-communicable diseases in Oman, the ones who were not able or affected by the pandemic and underwent complications? I think that's the question that they had.
I would love to have that data, Dr. AbulAziz, and I think many of us, even in the governorates, would love to have that data. It's very important. Even those who are may have been infected with COVID-19 and then have gone to develop chronic diseases, chronic lung diseases, chronic kidney diseases, type 1 diabetes in children, whatever the complication is with this new disease. Unfortunately, the actual impact of COVID-19 on our NCD patients, we don't have it yet, but it is something that we will need to consider. I think at all teams, in all governorates, we will need to start having that information to know exactly what has happened and what is happening. We're still in the pandemic, so we really still need to make these decisions as well.
Thank you very much, Dr. Shadha, and I think there has been a note from Dr. Zahir. I think we had a great interaction, so that's why I think we didn't care much about the time. But I think, is it okay, Dr. Zahir, just to ask each of our speakers to give us a few words at the end? Okay. So maybe we'll start with you, Dr. Shadha. What will be your last words to our audience on the topic of NCDs and COVID-19?
First of all, I'd like to thank Dr. Zahir and Dr. AbulAziz for the invitation, and it's a very well thought of webinar and topics. With regards to NCDs, remembering that we're still in the pandemic, we know that NCDs were always a vulnerable group. They continue to be a vulnerable group now with COVID-19. So there's a lot to be considered. The work that has happened in the governorates is remarkable. Thankfully, even when we share the experience of Oman in different platforms internationally, everyone is amazed with how much work has happened. So I'm very thankful for the teams in the governorates and the team centrally as well for the role and the different healthcare providers around Oman for their role. But there's so much yet to be done, and we're open for these thoughts and any collaborative work. It will be good to really focus back on those with NCDs now.
Thank you
Over
very
to
much,
you,
Dr.
Dr.
Shadha.
AbulAziz.
Thank you. Dr. Badriya, final words.
Thank you. Thank you very much, Dr. AbulAziz and Dr. Zahir, for arranging this. Really, it is amazing, and what is being done in Ministry of Health and the governorate, which is dealing with NCD during this pandemic. And happy to collaborate with our colleagues in the Ministry of Health with their and sharing with them the how we can improve our services. I mean, for best care for our patients. Thank you very much to all. Thank you, Dr. Zahir.
Thank you, Dr. Badriya. Dr. Laila.
Yes, I'm really thanking you, Dr. AbulAziz and Dr. Zahir. It was very useful for me. This discussion was very nice discussion. Thank you very much to give us a chance to share with you some of our initiative. And I hope that this pandemic will end with so many nice initiatives. And I'm sure that it will lead us to make so many initiatives, inshallah. Thank you very much.
Thank you. Dr. Zahir, do you want to end?
Okay. Thank you, Dr. AbulAziz. If you want to, Dr. AbulAziz, would you like to give any message or also like a word?
I think it was a great evening. I enjoyed it very much. Thank you very much, Dr. Zahir, for the idea and for selecting our speakers. And it was really useful and very interesting, and really opened lots of ideas and lots of thoughts about the pandemic and its impact on NCDs. Thank you very much.
Yeah. Thank you, Dr. AbulAziz, and thank you, the speakers. As Dr. AbulAziz said, it is an eye-opener. I think already some of the eyes have been opened to some of the research topics, initiatives to be improved or initiatives to be taken in Durham, in primary healthcare and NCD, and good lessons to learn. As Dr. Shadha said, we need to improve our medical ethics, our legislation, policies to get over with the COVID-19. And it is like a step forward. I think, as Shadha said, it is like telemedicine should come to persist and to sustain our medical services, and our health information system should be supportive of the telemedicine and other, initiatives in the medical field. Thanks a lot for the speakers, and thanks for the attendees and Dr. AbulAziz for sharing the session. We'll send you by email the CME's evaluation for the attendees, and then we'll send you the credit hours by email to your email address. And thanks a lot. Second session will come, inshallah, after 1 week, about the bariatric surgery and nutritional approach in primary healthcare, because we get now a lot of patients with the weight control surgery. We have a lot of questions: what medication to be started, what evaluation to be done. This will be, inshallah, announced soon in the coming session. Thanks a lot, and welcome to Oman Family Medicine Society seminar sessions. And assalamu alaikum wa rahmatullahi wa barakatuh. Thanks a lot.
Thank you.
Thank you.